Here.
Okay. Good afternoon. Welcome, everybody. We'll go ahead and get started. Thank you for joining us this afternoon. My name is Malachi Bishop, and I'm a professor in the Rehabilitation Psychology program here at the University of Wisconsin-Madison. And I'm joined in this presentation by Dr. Michael Frayne, professor at Florida Atlantic University, Boca Raton. And we will be discussing the evolving and often overlooked potential of self-management and rehabilitation, the example of multiple sclerosis self-management. We're talking about self-management, and we're using multiple sclerosis as an example because Michael and I have been working in MS self-management for about a decade now, and we're going to talk about some measures and how those might be used in rehabilitation counseling. We're going to talk about the ethical responsibility and the professional responsibility of being aware of and considering self-management in rehabilitation counseling. Any research that we talked about today would have been funded through research grants from the National Multiple Sclerosis Society, and we want to thank the society, and in particular the chapters and members, participants who have enabled the development and evaluation of this research over the last 18 years. Dr. Frayne will be talking now about self-management.
So in order to get ethics credit for this, Stacy said we need at least 48 slides. So the first 12 slides don't really matter, right? They're just filler slides that we're not going to tell CRC or anybody else about, right?
Sitting in the lobby right now.
No, what I meant to say there was Malachi was going to talk about those first 12, but he lost his notes last night at that place he went to. Anyway, so moving on. Thanks for being here. Thanks for being here on a Thursday afternoon when it's finally warm in Wisconsin, for Wisconsin at least, right? It's 43 out there or something like that, I believe, right? So some of you are asking, as I was walking through, you guys were asking, I know you guys aren't asking right now because it's always tough to ask questions in the middle of the big room. Some of you are asking, how did you and Malachi get together on this, right? Malachi, tall, smart, good looking, right? Then there's me. So a long time ago, when we both had dark hair, Malachi was presenting on MS at this conference. I was presenting on HIV. And much like, remember those old Reese's peanut butter commercials where that guy's walking around with the chocolate bar and someone else is walking around with a can of peanut butter? Who walks around with a can of peanut butter, you think? But, in the old days, those are the kind of commercials we had. Right? And then they bump into each other and the chocolate goes into peanut butter and they eat it and they find, wow, this is even better than the peanut butter alone. Because peanut butter alone isn't really very good anyway, right? So that's how me and Malachi kind of got together. We were both doing the same thing. He was doing MS, I was doing HIV. They're more or less the same disease. Well, they're a little bit different, but they're both chronic conditions, right? So other similar chronic conditions we found, as we read fine work from Chuck over there, right? There's similar chronic conditions like heart disease, arthritis, diabetes. Anything else? Okay. What's that? Brain injury. Yeah, I was pointing it to. Let me update our notes for our next presentation. Sure. People at home, Stacy's going to jump in and repeat the question or repeat the observation.
Comment from the audience was that brain injury is also a chronic condition.
Interesting, because so what we find with all of them, brain injury included, is while they're obviously unique in many ways, and we don't treat them all as one, but they share a lot of commonalities as far as the individual and what the individual can do early on to impact that condition going on for a lifetime. So someone with a brain injury, if they do certain trainings, right, they have a better life 10 years from now. Someone with HIV, they might not be showing any symptoms, but if they take the medication now, they get to live past 26. The difficulty, of course, with a lot of these chronic conditions is it requires people to maintain sometimes a difficult medication requirements. They got to eat food that's not nearly as good as the food that Stacy got for us here today. Diet and exercise, things that Malachi still does, but I forgot about a few years ago. And oftentimes they're doing these things while they're still healthy. So with MS conditions, with HIV, with not so much brain injury, I guess, but we'll figure out how to work that in. Someone might be having a healthy day and they're taking medication which makes them feel bad. So it's obvious the idea of self-management, where it seems common sense on the outside, it can also often be very difficult. It's kind of like someone smoking, right? Someone smokes, they're going to die a little bit sooner, but they enjoy it that day. There's lots of reasons, right? It cuts down anxiety, whatever else it does that I talk about in substance abuse class. If you want to come tonight, 4:20, I'll be on Zoom. Feel free to jump in. But it can be difficult, right? It can be difficult for someone to self-manage a condition that's not affecting them much now. So people have to attempt to figure out the psychological, the social, along with the medical aspects of a condition that's going to impact something about them 20 or 30 years down the road, as well as today and tomorrow. Kind of covered that, right? So self-management, it's a multi-dimensional construct, right? It's trying to unify the things the individual is going to be responsible for on a day-to-day battle of symptom management. And the idea with self-management is it's the individual. We putting the onus on the individual as opposed to the medical provider. So it's a lot different than what most of us do when we go to see a medical doctor. Usually it's a very passive experience. We go to see the doctor, they do a few tests on us and they tell us what's wrong, and then they tell us what medication they can take, they tell us what to do. With self-management, with chronic illness, what we're promoting here is that it's on the individual. So we're sort of we're empowering the individual to take an active role in their life, in their chronic condition. Before Malachi came along, Laura defined self-management as learning and practicing the skills needed to carry on an active and emotionally satisfying life while living with a chronic condition. Now, you could argue that we're all trying to maintain an active, emotional, and socially good life, but Laura didn't talk about people without chronic conditions. So we all see the similarities between the self-management and what we're all trying to do with or without a disability. With self-management, we talk about three main themes. Medical management, which is kind of the most important, what most people think about. It's that informed monitoring, managing the disease, understanding what your disease is. So if you have HIV, you understand what certain symptoms mean, you understand what certain CD4 counts matter. And you understand what you can do to affect those kind of things. So we know with things like diabetes, people are right, they're taking their blood sugar and they know when they see certain numbers that they have to do certain things. I'm not really sure what those things are because, I'm not a researcher on that. But if you talk about MS, we could talk about that. That's on slide 17. We'll get there in a second. The second thing is role management. So with a chronic condition, especially being diagnosed with a chronic condition, when we talk about brain injury, when we talk about MS, when we talk about HIV, it's usually happening, the diagnosis usually happens fairly young. If you think about who has head injuries, it's people who are skateboarding, doing, not just people who are skateboarding, but people who are younger doing fun things usually. With HIV, it's oftentimes in the 18 to 25-year-old when you're first getting diagnosed, and same with MS, where it can be diagnosed a little bit earlier. We usually see it between 20 and 50, and usually on the earlier end. If you think about what's going on at those early 20 years, vocational, what are we going to do for work? What are we going to do about family, social life, those sort of things? So with MS, what we're talking about with self-management is people taking a conscious thought of how do I want to live my life now that I have this chronic condition, which leads to a lot of fatigue. It leads to a difference probably later on in life. So what we want with self-management is for people to be conscious that their life is going to be maybe a little bit different, and how do they want that life to be? So with work, it could be that instead of having a job that you have to travel a lot, maybe it makes sense to go into a profession that you work more from home or you work closer to your home. With family life, maybe it's a thought of how many children do I want to have? what's going to be my role with children? Maybe I'm looking for a partner who's going to be able to help more with children than I originally thought. The third part of the self-management model, so to speak, is that emotional management. So the emotional management is both in coping with the idea that suddenly I'm 21 years old and now I have MS, and I'm a whole different person, so to speak, or my mindset might be a little bit different, but also the emotional impact of having to make changes in your life that can seem somewhat unfair at early 20s, having to think about taking a different role in work than your colleagues are taking, perhaps, because of this condition that sort of was put upon you for no fault of your own, usually, right? So while the multiple sclerosis self-management scale could fit for many chronic conditions, since it has multiple sclerosis in the title, we figured we would center it on multiple sclerosis. Thanks for the slight chuckle there, Molly. I appreciate you looking out there. So with MS, the self-management scale focuses a little bit about learning the condition and symptoms and its treatments, being able to continually monitor your health status, and things like maintaining healthy lifestyle, healthy diet, healthy life choices. A little bit, and also when we think about a whole life experience, some of that's also the supporting social and cultivating social and family relationships. So oftentimes we already have family or we have a social circle when we're diagnosed with a chronic condition. So one thought of self-management is the individual needs to cultivate those relationships so people understand what you need with this new condition. So if you need more rest, if you need to not take the same kind of vacations, if you need more help with childcare, if you need help at work, how do we talk to other people about that? How do we talk to our supervisors? How do we talk to our significant others to understand what we're going to need in life so that not only are we trying to have supportive relationships, but we're cultivating those supportive relationships so those around us can help with our condition. Another sort of important aspect with self-management and with most chronic conditions is also managing your healthcare providers. Oftentimes you're seeing more than one healthcare provider for one, so you need to be the one that connects those healthcare providers together, which is anyone who's dealing with more than one doctor at once can be very difficult for people to share information or to get a consistent message from all your healthcare providers and a similar goal with your healthcare providers. With MS, there can be fatigue, pain, changes in cognitive functioning that need to be managed. So it can be a big change for someone in their early 20s and changes in lots of different aspects of life. A little bit about MS. It affects about 900,000 Americans. It's a chronic condition, 3 times as likely in females. I had a little female joke here, but Stacy asked that I not do anything like that up here. So can be diagnosed early, but usually from 20 to 50. And the unique thing with them, not the unique thing, but something that is interesting about MS is the intermittent and recurrent episodes. So oftentimes someone has MS, they have the symptoms of MS for one day or for 1 month, and then they feel better the next month, but they're aware that it's going to come back again. So arguably, it's kind of a tougher disease to deal with because it comes and goes. There's no cure. The treatment is symptom relief and long-term use of disease-modifying treatments. The other a little bit unique thing about MS is that it's very individualized. There's no course of treatment. There's no similar symptoms that everyone's going to experience. So one difficult thing, if you think about when diseases aren't similar, is oftentimes if you have MS, someone else has MS, the other person might be doing things that you can't do. So your spouse is wondering, your significant other is wondering, this person has MS and they're able to do all these things. Why can't you do these things? So with MS, we see that it's very individualized. It's not as easy to talk to someone who's had it and say, all right, this is going to be what's going to happen 5 years from now. This is going to happen. This is going to happen. So that unknown, the variability and the unknown can make things difficult and makes self-management all the more important. Some common symptoms of MS, fatigue, of course, is the big one. But other things, cognitive impairment, that's why I'm speaking today, because we won't go there either. And some other things that obviously affect work as well. The chronic pain oftentimes can lead to lower productivity, anxiety, depression, mobility issues. And what we find with a lot of these things that they're sort of hidden disabilities. So when we're trying to talk to someone, supervisors at work or significant others, they're not seeing the disability. So it can be difficult to explain how MS is affecting you one day and not affecting you another day. Good, ready? We're gonna jump back over to Malachi and take it away.
Yeah, Michael's way more fun. He'll be back in a minute. I'm going to say a few things about MS treatment that people should be aware of. MS treatments are aimed at modifying the MS course, managing relapses, and managing the ongoing symptoms. Disease-modifying therapies, term I'm sure you're familiar with. It's the basis of treatment for relapsing, remitting, and secondary progressive MS. It does reduce the number and severity of attacks, reduce disease activity, and delay the onset of disability. The important thing to know about the disease-modifying therapies, they've changed over the last couple of decades. They were, injection, and they're associated with a lot of problematic side effects, basically. The quote here from one of the studies we did: the side effect of the disease-modifying drug knocked me out for at least 24 hours, if not 48. I feel like I just get back to feeling 100% when it's time to take the medication again. I'm willing to do it because I haven't had a relapse in 6 years. There are currently 27 FDA-approved disease-modifying therapies, 10 injectables, 11 oral medications, and 6 infused medications. And we were, people were very excited when the orals came out because we thought it would improve adherence and, the issues that people were having with using the DMTs. And to some extent they did, but adherence is between 41 and 88% with the disease-modifying therapies. Despite the development of the oral DMDs, we're still seeing adherence. 1 in 4 discontinue daily oral DMDs before 1 year. If adherence to treatment is poor, medication will have limited clinical effectiveness. It doesn't work unless you're taking it. But it's one of those conditions, one of those medications where, almost the treatment sometimes feels worse than the disease. It's very problematic. I think it's important for rehabilitation counselors to be aware of that. And then I think I'm going 1 sec, sorry. All right, here's the ethics part. I think, and I've been trying to convince Michael, so see what you think. I think that based on what Michael was talking about in terms of the things that are involved in self-management, right? And our role in that. So the whole point of self-management is that the client is managing their own health, right? And we are respecting that. But our role as rehabilitation counselors, I think, is education sometimes, advocacy, either teaching advocacy, promoting self-advocacy, and sometimes direct advocacy, and providing resources that help promote the individual in their self-management of the condition. And Michael talked about interaction with healthcare. And Dr. Chung-Yi Chu at Illinois and she and I did some research a few years ago about interactions with healthcare. And we found things like, basically like all of just from going to the doctor, right? You usually need more time, you usually want more time than you get with your physician, right? When you're dealing with a chronic illness, that's even more the case. And so self-advocacy becomes very important. Education about, all right, so how do you deal with that? Maybe we write down a list of questions before you go in, and you make sure that you make the time to ask those questions. You do a log about treatment and side effects and what's happening, and you bring that with you. All right, so there are all sorts of advocacy and education components of that. Michael talked about role changes and the emotions involved in that. And that makes me think about participation in employment, participation in other things that people do. I was trying to think what other people do. I don't do anything but like teach. So, and research. I don't really have a life, but I was trying to think, what else do you do? A lot of, Michael does a ton of stuff. Just a second. What do you do?
Bike here, right?
Yeah, I do bike. Yeah. I bike and yeah. But other people do stuff, right? You participate in the community. And so here's where I see the ethics come in. I think it is particularly identified in terms of our responsibility in section C, advocacy and accessibility. And forgive me for reading for a second. I didn't memorize these, but I actually, of course, I do have them memorized, the code of ethics. But let me go ahead and read it just in case you don't. Attitudinal barriers. CRCs recognize and address attitudinal barriers in applicable settings, including employment, education, healthcare, community inclusion, that inhibit the growth and development of their clients, right? So I think that's related. Areas of knowledge and competency. CRCs are knowledgeable about systems and laws, as well as organizational policies and how they affect access to, same list, education, transportation, housing, civil rights, medical services, and mental health services for individuals with disabilities. Knowledge of benefit systems. CRCs are aware that disability benefit systems directly affect the quality of life of clients, as well as clients' motivation and interest in pursuing personal, career, and independent living goals. CRCs provide accurate and timely information and resources to individuals. So education, advocacy, knowing what you have the right to and being able to make sure that our clients are aware of that. Barriers in terms of accessibility, barriers to services. In that study that Chung-Yi Chu and I did, we found significant barriers to healthcare. People using wheelchairs, and either the examination equipment wasn't accessible, or the people there just didn't want to do the work that it takes to make the equipment accessible. I was working in Kentucky for a long time, but I know this is true in every state with large rural areas. But we found people were traveling hour, 2 hours, 3 hours. I mean, basically, if you live anywhere east of Lexington, Kentucky, you're talking about traveling to the University of Kentucky, right? And if you live in Western Kentucky, you're talking about coming to Louisville. Both of those are hours away. And so access, all kinds of access issues related to that. So barriers to services, CRCs collaborate with clients and other stakeholders to identify and develop a plan to address physical, programmatic, structural, attitudinal, or technological barriers to services. And then last one, barriers to community inclusion. Talk about the role component. CRCs promote the welfare of individuals with disabilities to maximize their potential for community integration. They engage in community collaboration when feasible to address systematic barriers to fair and equitable access, participation, and inclusion. So the way I see that, when we talk about self-management, and we're going to talk about how we can integrate self-management in rehabilitation counseling, to me, there's clearly an ethical responsibility involved in this. To me, it's very evident. I think we move to the scale now. So now, I can't hear Michael very well from sitting behind because there's an echo. Something about peanut butter and chocolate.
It's hard to do that.
Back then when we were making peanut butter and chocolate together or whatever, we began working together on a scale, a self-management scale for people with MS. And we approached that in a number of ways. We wanted to make sure that we were addressing the experience of people with MS, healthcare providers, and other professionals. We wanted to make sure that we had a lot of perspectives. And so we looked at the research, and since then we've done other research. And one of those things that Michael and I did with some other people was look at what are the life domains that are important to quality of life for people with MS. And we found it's not that earth-shattering, but we found that health was a top priority. It was the second priority, actually, family, and then health. And then a lot of other important things. But health is something that people with MS talk about a lot. The MS Society has been doing a lot of work in wellness the last few years. And people with MS are saying, we want wellness. We want to learn about how we can keep ourselves well. A lot of people with MS, you can let me know if you've heard this from people with other conditions, but particularly with people with MS, that say, MS has taken so much away from me and it controls so much of my life. I want to control what I can, and this is something that I can control. I can control my diet. I can control exercise. I can control some of this stuff, and I want to maintain that control. Self-management, to me, is really about helping them do that. Another quote, MS is a chronic disease with fatigue issues, mobility issues. This affects my independence. I no longer drive, and so I'm dependent on others to get to work, shop, go to entertainment, etc. This affects my relationships, dependence on others, intimacy, etc. I need to exercise more, but I get weak and fatigued too quickly. So it's the point is it affects many domains of a person's life, and we also wanted to make sure that we are addressing that part. So Michael's going to talk about the work we did with developing the MS self-management scale.
Thanks. Right, I couldn't hear you back there very well. So Malachi's correct there. We were trying to develop a scale, and kind of our idea behind the scale, a couple different parts. One part was to try to get help healthcare providers and the individual understand where they are with their MS. So sort of help them create maybe call it like a life care plan, understanding what things that maybe they have to work on. And also, it's a scale that can be taken over time. So to see where some improvements coming, if you're working as a healthcare provider and giving it to people, you can see some improvement over time in some areas, and maybe some decline over time in some areas. Right? Some of us can keep a diet for a little while, but after 6 months, maybe we go downhill. So we developed it in 2007. We gave it to Malachi, got a grant. It's always fortunate to work with Malachi because he gets lots of grants, and I just kind of coattail off the back of him and get a couple of publications, right? So it was specific to MS when we first did it. We were trying to create an instrument that was multidimensional, looking at the factors that we saw were important to people with MS. And we also got some consultation with both people, obviously, with MS, but also MS experts and healthcare providers in the field. Mainly some neurologists. If you're ever in the healthcare, if you're ever in MS, who gets all the grants? The neurologists get the grants, right? They don't know MS as well as we do, but they get the grants. So they're the other people that we like, neurologists in general, just not when they take our grants away, as well as other people these days taking away our grants. But anyway, cut that from the DC portion of our thing here, right? So we did well, more or less, Malachi had a graduate student do a good comprehensive review of the MS and self-management literature. A lot of stuff from Lorig, a lot of stuff from the late great Robert Fraser. So we included those things in our scale. We tested it on 266 individuals who are part of the MS Society. We did a good factor analysis, and we came up with a seven-factor scale. Going back to Fong Chan's class on factor analysis, I took out that old notebook, right? And I had like things written on the side, right, to figure out the factor analysis. And then I just gave it to Malachi and he figured it out himself. So what we're looking at, treatment adherence was a big part. We've done some stuff on adherence. And if you talk to doctors, what do they think our adherence rates are? They all think we have like 100% adherence on medication, right? In reality, as Malachi's slide, you agree? What's that? Adherence is low, right? But if you talk to doctors, they all think it's high. They all think we're taking our medication all the time. In reality, with MS, with a lot of diseases, we're about a 50% rate, right? So there's lots of good reasons why we don't take our medication, right? It makes us feel bad. We forget, we put it in our backpack and then we're riding to school and it drops out of our backpack and we can't find it and someone else takes our medication and they're feeling really healthy, but we're not. We knew that from the instrument that or from our previous surveys that whole provider relationship was very important, and that came out in our factor as well. Emotional and social health, social support, being aware of your health symptoms. And as we're talking about this, for those of you who look at other chronic illnesses, you can see where your own stuff can kind of fit in. So we're talking about brain injury, we talk about arthritis. It's a lot of the same kind of factors. Some of the questions are just slightly different, right? So with MS, fatigue might be the question we're talking about. With brain injury, it would maybe not be fatigue, but it might be something similar, right? I'm not sure what that would be, but health maintenance behavior came out as a clear factor, as well as communication and understanding symptom changes. Construct validity was supported with other quality of life measures and the impact of MS scale. Internal consistency, reliability for scale was pretty good, 0.86. We're not doing a dissertation here, right? We'll accept that one. So we had this scale for a little while. A couple of people used it, Then came along 2011. I was going up for tenure. We needed a few more articles real quick. So we decided that we would redo the scale, right? Revise the scale. So in 2011, we kind of did the same thing. Malachy got another grant, and we recruited lots of individuals to take it. We came up with a similar, but now a five-factor scale, which makes it much easier to do our whatever word I was going to use there, that was going to be really good. So we came up with similar kind of things. Healthcare provider relationship was important. Adherence barriers, social family support, those sorts of things. MS knowledge and information comes up big a lot, right? Because a lot of people we don't naturally know about MS. So that whole idea of what do symptoms mean, what kind of symptoms can I expect? Why am I feeling this way? Is it my MS or is it just that I'm getting older, right? Why am I losing my hair? It's not because of MS. It's because, well, my dad lost his hair and, he also lost his wallet a lot, but that's another factor, but not going here. So the MS, what we found with the revised scale for some reason, do we know the reason? Became very popular, right? It's now been translated into like 16 languages, Portuguese, Spanish, other things that are written up there, French, Arabic. We get a lot of requests to use the scale in dissertations or in healthcare services. When we first developed the scale, we didn't really think anybody would use it. Otherwise, we would have contacted Stolting and we would charge people to use the scale and we would have more money now and we would not have to ride our bike to school anymore. But it is free. So for all you out there looking for scales to use, it's a free scale. If you do use it in your research, we ask that you send your results. We're trying to get a meta-analysis together one day. And besides using it for your own research, the other aspect, like we're talking about, is it can be used in lots of different chronic conditions with just a slight variation. We've tried to use it with HIV before, but it can be used in lots of different healthcare settings by just changing around a couple of the questions on it. So what are the questions on it you're asking? I saw your hand coming up, so I'd try to go in front of you there. Well, first we're going to go with what it correlates with, because that's always important to get to before you get to the questions. So it correlates with social support, perceived control, treatment control, the Muse, the illness uncertainty scale. Anybody use that in your dissertation? That was a good one. Because uncertainty, we know that uncertainty leads to anxiety and leads to lots of bad health outcomes. So when we're talking as rehabilitation counselors, one thing that we want to give is information. When people are uncertain about the disease, things go south and they usually think negatively about their future and things like that. And they also don't take the proactive things they need to do when you're uncertain about what kind of treatment or what kind of activities you should be engaging in. Uh, so with a few of the scales, with a few people who have used the scale, they have found other aspects of the MSSMR. It's always difficult for me to pronounce that. For one, it had good retest reliability. We think it can be a scale that can be used over and over with the same person, as long as they're not lying on the scale, right? It makes sense. And it's fairly well correlated with scales regularly used to assess other parts of self-management. The PIH-12 health education impact questionnaire. So by a few years ago, what we have found that the current instrument is appropriately used both in individual settings and also as a rehabilitation counselor, or more appropriately probably in healthcare settings. We probably need to add a few items at this point to reflect different self-management priorities as maybe times are changing, and also just as we gotten feedback from it. So the access to healthcare has changed a lot from 2010, if you think about it. Also, the idea of adhering to diet, some nutritional kind of things have evolved over time. The use of cell phones, you think about that, like everything's on your cell phone now. When we first did this, I was still using my rotary phone. So some things about life has changed in the 15 or 20 years since this scale has been developed. And also the way we interact with doctors is much different now. It's often telehealth, where the amount of time we see doctors has continued to decrease. So we've we had almost 2,500 people take the MS scale, with the majority being female. Anything you want to jump in on this one here? Or? Okay. Come on, yeah. You can.
Yeah. So basically, we decided there's been a lot of developments, and people are giving us feedback about some things that we should do to change the scale. So we developed the MSSM2, and we'll get into the details of that process. But about 2 years, no, it was 22. I think we published it in JARC, the Journal of Applied Rehabilitation Counseling. We added 8 items, and we were focusing on things that people with MS were telling us that they wanted more focus on. So fatigue management, access to healthcare, health promotion, things that people are doing in terms of diet and nutrition, exercise, complementary or alternative approaches, and other symptom management techniques like visualization, yoga, prayer, and meditation, and so on. And they wanted us to add an NA because a lot of people, it does have not focus, but it does have items about adherence, and it definitely has items about interaction with the healthcare provider. And some people didn't like the medication questions, so they said add a NA option, and we did that. So it's a little different, but it's basically the same in terms of the length and reliability and the factors. Not as much research has been done with this one yet, but we are hopeful that it will pick up. Everybody loves the MSSMR, and it's still a very useful scale. Is that what you were asking about, the items? Was that your question? Okay. So some examples of the factors and items. There's a healthcare factor, healthcare provider relationship and communication. I'm comfortable discussing my questions with my healthcare provider. I'm satisfied with how often I see my healthcare providers. I feel like I'm involved in decisions about my treatment. All of these are based on a 5-item Likert agreement scale. Health promotion, things like I try to promote my health through diet and nutrition. I promote my mental and physical health through yoga, meditation, prayer, relaxation, and so on. Taking my medication is a routine part of my regular activities like brushing my teeth, treatment adherence. I'm confident I need to take my medication to be healthy. There's social and family support items. My immediate family is supportive of me in handling my condition. I have friends who are supportive of me in handling my condition. And then the MS knowledge and information. I seek out information about my MS, and there are a few others about that. But the person's understanding of their condition, health maintenance, behavior prevention, 4 items on that. Examples would be I have found effective ways of managing my fatigue, or I tried to schedule my day so that I do not become overtired. And then the adherence barriers. Sometimes I still forget to take my medication. Side effects should make it very difficult for me to take medications as I should. What we are proposing, and Michael alluded to, is that as you look at the items, hopefully you see that the references to my condition typically, there are a few specific MS worded questions. But as he said, even though this is the only MS specific self-management scale, we think it works well as a general scale that rehabilitation counselors could use in an intake interview. You could give them the scale and they can complete it in a few minutes. And it would provide a nice sort of snapshot of where the person might be struggling or want more information or want to do some education and advocacy work in terms of things I was talking about before, talking to the healthcare provider, participating in community. We recognize that we are not medical providers. And ethically, we have to be careful about any conversations we have about health-related questions, right? But we think self-management does not require us to be. It is consistent with all the goals of our profession in terms of being holistic, in terms of promoting assets and strengths, and in terms of being directed by our client. We think a brief conversation guided by a self-management outline, it could be this one, or it could be another, can be an efficient, impactful, lasting technique and promote rehabilitation counseling goal attainment. Because as I know I've said a few times today in different presentations, if you're healthy, if you feel like you're managing your life, your condition, sorry, and you are feeling well, then you're more likely to be working and participating and have better mental health and so on. A lot of positive outcomes related to what we are working with people on in rehabilitation counseling. Michael said it's still free, and we are still kicking ourselves about that, but it is still free. All you have to do is reach out to myself or Michael and request it. There's some students in here. I would say we get probably a request every month or two still. About a third are PhD dissertations or master's projects. About a third are clinical requests, and then about a third are research requests. We respond pretty quickly to the email. We send you the scale and some supporting materials.
We have time for one easy question from Stacy, I believe.
I think we're good. The question was posed about whether the full MSSM2 was available and how to request it. And then your slide came up.
Right.
So I'm assuming Elizabeth Bull now has her question answered. Thank you.
One minute, so you gotta tell a story about telling the rehab program.
Yeah, I think we're good. If we're here, if there are no other questions, we appreciate maybe a question. Sorry.
A very interesting presentation. I really appreciate the work you guys have done on MS. I think you really have advanced the field, in terms of self-management, and yeah, I think it's a condition a lot of people don't really understand, and I think again the work you're doing really has advanced you know, the understanding within the profession, but also, I think also for families and individuals who are affected, you know, by MS personally. I think it's given them a lot of information and hope for the future. You know, one of the things, you know, Michael, you talked about like applicability to other populations, and as you're going through the items, I actually think a lot of those do apply to brain injury, you know, maybe all the items in some degree, you know, and I suspect maybe changing a few words here or there, it's really a universal scale for chronic conditions, chronic progressive conditions. And, you know, Malachi, I went to your presentation yesterday on long COVID, and it seemed like a lot of what you talked about there applied to what you talked about today. And, you know, generally, how do you both feel about long COVID and MS? Do you see them as a lot of, you know, crossover in terms of the long-term effects of this, you know, self-management as an intervention technique for those two conditions? What are your thoughts about the relationship among the two?
Yeah, it's actually, I hadn't thought of it in that context myself, but I think that's a great question. And now I'm thinking about it, there is a lot of overlap, isn't there? There's a lot of stigma and discrimination associated with both of them. Both of them are sort of, you know, MS, like long COVID, diagnosis is lengthy, not always certain, certainly with long COVID. Long COVID is developing, as we talked about yesterday. So, but yeah, no, I think great overlap. Yeah, a lot of overlap. Yes, all right.
Thanks for your time. Thanks for being
Yeah.
here on a Thursday afternoon.
Thank you, everyone. Appreciate it.